This is the Emergency Medical Minute, sponsored by CarePoint and HCA Health One.
Okay, so I'm going to talk about a case that I had on my last shift, just because they brought up some interesting points and something that is kind of my practice pattern and some people's practice pattern that's not super evidence-based per se, and I don't see a lot of people doing this, but it works really well for me. So we had a patient that was a very sick asthmatic. A young lady came in and was on BiPAP, and this is something we do see occasionally, and most of the time, BiPAP does work really well for, very sick asthmatics. But often, sometimes, especially if they've never been on BiPAP before, they get very anxious. And it's this combination of this mask feels like it's smothering them, and just that air hunger of, having really bad asthma, they get very anxious and can even be fairly uncooperative. And, I think a lot of times the go-to first medication that people kind of expect and that EMS crews sometimes also expect or want to use is a benzo. Like, let's give them some Ativan, let's give them some Versed. They're really anxious, so let's treat their anxiety with our usual anxiety meds, which works for, the vast majority of other diseases. But I actually very much try to stay away from benzos in critically ill asthma. And I actually go to fentanyl as my anxiolytic for asthma, which sometimes I get funny looks at first when I do this, but fentanyl actually does a really good job at treating anxiety in asthmatics, because part of their anxiety is air hunger, is that just shortness of breath and hypoxia that they're experiencing. And opiates are really good at preventing pain and distress from air hunger. It's why it's in comfort care measures. Opiates are very commonly used for patients who are short of breath. And I like it too because it's very titratable. So actually what I do is 25 micrograms, Q 5 minutes. So it's pretty intensive. You're kind of standing right there, but giving them baby doses of fentanyl as needed in these small doses until they clinically seem more comfortable and are actually tolerating the mask better, because it just tends to decrease it doesn't decrease the respiratory drive as much as benzos do. I actually had the only time I've ever had a patient, an asthmatic, actually die, who came in on BiPAP, who was a really difficult airway, was like morbidly obese asthmatic, who got a dose of Ativan, and that just tanked their respiratory drive so much, they just basically stopped breathing. And then we were bagging them, trying to intubate them, and ended up arresting, weren't able to get the airway, and ended up dying. And that always stuck with me and kind of made me pretty afraid of using Ativan in critically ill asthma. And then found there's not great literature in terms of like RCTs or trials comparing the two, because it's not a very common illness. It's pretty hard to do a study on something like that. But there are people who write articles and in literature who do recommend avoiding benzos in asthma. And so I've had really good success with using fentanyl as my early dosing. And then if the fentanyl's not working, and if they're still really anxious, still just not tolerating the mask, and that's a patient who's getting ready, you probably are going to intubate them, but I still don't go to a benzo. I move toward to ketamine. But if you're going to give somebody ketamine for asthma, you're getting ready that there's a very high chance that they're going to need to be intubated. But yeah, so I use fentanyl for only the patient who's very anxious and is not able to be coached through BiPAP, because anytime you're giving these medications, okay, this is now the next level of critically ill asthma. And the other big trouble with any of those medications is usually we can assess how they're doing by the respiratory rate, how they look, do they seem more comfortable? Like if their rate starts at 40 and then their rate's down to 20, you say, oh, the BiPAP's helping, they're doing better. Once you've given them a sedative, you don't really know, is it that they're feeling better and that's why their rate has come down, or are they sedated and that's why they're coming down? So that's just a patient that you need to really tighten up your VBGs you're getting, because you actually need to use VBGs to assess their PCO2, assess are they getting better, or are they just getting sleepy and tired and they're not fighting anymore because they've got an opiate. So it does make your clinical assessment a little bit trickier, but I find it definitely helps them stay on BiPAP and prevent intubations.
This has been the Emergency Medical Minute. Thank you to our sponsors CarePoint and HCA Health One. Support from them and listeners like you helps us to continue providing free medical education to the masses. If you found this episode valuable, consider supporting our work and check out the link in our show notes.